Hi, I am Dr. Joselle Cook from Mayo Clinic in Rochester, Minnesota. And I'm so thrilled to share with everyone the exciting results of our phase 1 clinical trial in which vesicular stomatitis virus engineered with interferon-beta and sodium iodide symporter was administered as a one-time single-dose intravenous therapy in patients with relapse and refractory malignancies, hematologic malignancies. While most of us in the field have heard of the success of intratumorally administered TVEC, so far the success of intravenous oncolytic virotherapy has been anecdotal. And so in this dose escalation trial, we enrolled a heavily pretreated cohort of patients with T-cell lymphoma, multiple myeloma, and AML, and determined the maximum tolerated dose of VSV-IFNβ-NIS to be administered as a single intravenous dose. As well, we determined the safety profile of this oncolytic virus and preliminary efficacy. We found that the virus infusions were well tolerated, even at the highest dose level, and we saw no dose-limiting toxicities. The major grade 3 and 4 adverse events were hematologic, and apart from that, we did see grade 2 cytokine release syndrome occurring most frequently at the highest dose level. The cytokine release syndrome, however, was very self-limiting, usually resolving within 24 to 48 hours, and was well managed with supportive cares, IV fluids, antipyretics, antiemetics, and that was so in all cases except for one, where a patient treated at the second dose level required transient norepinephrine support for 4 hours. In terms of results, we saw truly compelling responses at the highest dose level, even in this group of patients with multiply relapsed and refractory disseminated disease. There is a patient who experienced cutaneous relapse of her peripheral T-cell lymphoma who continues to enjoy complete response even 15 months after administration of VSV. We saw another deepening partial response over 6 months in another patient with peripheral T-cell lymphoma. And at dose level 2, there was a 3-month partial response in a patient with cutaneous T-cell lymphoma. The transgenes interferon-beta and sodium iodide symporter were encoded into the virus to boost tumor specificity, pro-inflammatory activity, and to facilitate in vivo trackability of VSV. And indeed, we found that the insertion of transgenes were useful for non-invasive monitoring, as the virally encoded interferon-beta served as a convenient marker of intratumoral amplification. In our other correlative studies, we found that viremia was quite short-lived, with levels rapidly declining after administration and no significant evidence of virus shedding. And so with this study, we have established not only that intravenous VSV is feasible, but have established the most effective and safe dose, which is tissue culture infective dose 1.7E11, that will produce clinical responses in a heavily pretreated cohort of T-cell lymphoma patients, a group of patients with limited treatment options. And this is really quite exciting for us. And so what is the wider context of this type of treatment? Well, at the highest dose level, we observed an overall response rate of 30% of all patients in that cohort and 50% overall response rate for the subset of T-cell lymphoma patients. This is significant for several reasons. First, there's an urgent need for novel therapies for patients with T-cell lymphoma. Most patients with T-cell lymphoma exhibit responses of about 30% after relapsing from frontline therapy, and our results are consistent with this. But even more importantly, it appears that we can achieve these responses with a single shot. And so this could be a one and done therapy for the patient and allowing the patient a break from ongoing cancer-directed therapies. We are currently proceeding with our dose expansion cohort, where we're treating patients at the highest dose level. And if that response signal holds up, this could be another new and novel treatment option for patients with T-cell lymphoma. How near do I think this is to clinical practice? Well, we've got our dose expansion going, and we're making plans for our single-arm study registration trial. And we are optimistic that this could reach clinical practice in a few years. In terms of limitations and challenges, the only limitation I can see is that it requires overnight hospitalization, and administration would be limited to specialist medical centers that can handle intravenous virotherapy. But otherwise, I don't foresee any other major challenges with this type of therapy. And so to summarize, these initial results are truly promising. And once this dose expansion arm gets accrued, we're potentially looking at a new and novel immune therapy with VSV-IFNβ-NIS to add to the limited treatment options for patients with T-cell lymphoma. This could be a one-shot therapy for the patient. Furthermore, what we've presented here is the first study of systemically administered VSV that bears clinical responses among patients with multiply relapsed hematologic malignancies. Thank you so much.